So I want to talk a little bit about endoluminal surgery this morning, and I think it's the future of minimally invasive colorectal surgery, but we'll explore it together. So these are my disclosures. So laparoscopy for colon surgery is becoming, or I think it has become, the gold standard. And there are many randomized controlled trials now that clearly demonstrate benefits. And Dr. Stamos also published that, currently about 50%, after about 15 years of doing it, of the colectomies in the United States are being done laparoscopically. And these are the benefits, as you all know: decreased pain, length of stay, quicker bowel function return, recovery, and also decreased wound infection rate. But the reality is, benefits are not as dramatic as we expected. So compared to open surgery, laparoscopic colectomy, length of stay decreased by 1 to 1.5 days, and slightly decreased pain after surgery. So how can we further improve upon the outcomes of these patients upon beyond laparoscopy? So there's been a lot of efforts to improve outcomes by doing node surgery. I'm going to talk a little bit about single port laparoscopic surgery, and now endoluminal surgery. So nodes, it stands for natural orifice transendoscopic surgery. It's a patented term, and it really took off about 10 years ago when a surgeon or GI surgeon from India showed a video taking out an appendix through stomach. They put an endoscope and a seemingly normal appendix, but it really, it didn't really tell you how you close the stomach and so forth, but it really triggered a lot of interest in a lot of surgeons in thinking differently about how we do surgery. And the potential benefit is that we're not creating any abdominal incisions, and we're replacing maybe somatic pain with the visceral discomfort. Maybe patients will have better outcome, but we really didn't know what the potential expenses would be. So, since then there are a lot of nodes procedures that's been done, mostly appendix or appendectomy or cholecystectomy, and certainly it is feasible, but certainly it's a different type of scenario for colon surgery, because it certainly poses much greater challenge. We're working in multiple quadrants, and we also need to reconstruct it, and we need to extract a very bulky specimen compared to appendix and gallbladders, and really had limited instrumentations. And I think at this point, what's really remaining, Matt will talk about this later on today, is really TA-TME. So we're through the anus, we're using Sill's port to take out the rectum,